Thank you. So Nada and I will share this presentation. I was thinking this morning, just like we did when you had group work in school back in the days, you take half each. So thank you for the nice introduction, and thank you for the invitation to come here and tell you about some of the work that we've been doing over the past few years. So I'm going to say a little tiny bit about what traumatic brain injury is and how it may affect return to work. I will tell you about the rationale and aims of a randomized controlled trial that we have recently conducted. I'll tell you about the study design, and Nada will talk us through the main results, and then we will come up with a few conclusions. So traumatic brain injury, for those who do not know, is defined as an alteration in brain function or other evidence of brain pathology that is caused by an external force. More than 50 million people sustain a TBI worldwide each year. In Norway, we estimate that there are somewhere between 10 and 12,000 persons, and approximately 4,000 people will be admitted to hospital each year due to a TBI. We classify the injury severity medically using a scale called the Glasgow Coma Scale, where the typical numbers will be that approximately 80 to 90% of traumatic brain injuries are classified as mild in a medical sense, although the consequences might not feel mild at all for those who suffer these injuries. And then 10 to 20% will have moderate to severe injuries. Traumatic brain injuries may result in a wide range of physical, cognitive, emotional, and behavioral consequences, where each of these categories may affect the potential to return to work. We know that among the mild traumatic brain injuries, approximately 90% or 80, somewhere between 80 and 90% will perceive themselves to be asymptomatic within the first 3 months after injury. But we do have a minority of patients who have experienced persistent symptoms over a longer period of time, and that is the subgroup of mild TBIs that we have addressed in this study, because persistent symptoms after brain injury will typically also affect their ability to get back to work. Although we do know that moderate to severe TBI, maybe 35% will have returned to work within the first year, and the numbers are much higher among the mild injuries, where we expect about 3/4 or even more to be back to work 1 year after the injury. We know that there's a very complex interrelationship between premorbid, injury-related, and contextual factors when it comes to return to work. And return to work is a key component of all brain injury rehabilitation, both for the patients who really want to get back to their life as it was before the injury, but also to professionals, because we know how important work is in the daily life of our patients. So before we started this study, we knew that there were some challenges in this field. For example, we know that interventions that we in the health sector typically provide, aiming to improve symptoms after TBI, do not necessarily result in increased return to work rates. There are also very few well-designed controlled studies on the effect of vocational interventions after mild to moderate TBI. Despite well-organized and universally accessible healthcare, unmet healthcare needs and return to work levels are not much better in Norway compared to other countries with much weaker healthcare systems. There is a need for more and better cross-sectorial collaboration between the healthcare system and the welfare system. And there is also a need for the healthcare system to take into account that return to work is only partially about the medical condition and its symptoms, and largely influenced by factors related to the workplace. I think many of my colleagues in the healthcare system think that if we just understand the symptoms, we can increase return to work, but we also need to understand the work system better. So that is what led us to conducting this trial that we called the Effect Evaluation of Combined Cognitive and Vocational Interventions after Mild to Moderate Traumatic Brain Injury, a randomized controlled trial, and a qualitative process evaluation. And as you see here, this is a collaboration between Oslo University Hospital, Sunnaas Rehabilitation Hospital, the Work Research Institute at Oslo Metropolitan University, the Norwegian Labour and Welfare Administration, the National Association for the Traumatically Injured, which is a user organization, and several international collaborators. The aims of the study, the primary objective of the study, was to evaluate the effectiveness of a combined manualized cognitive rehabilitation and supported employment in real-life competitive work settings for patients who have not returned to work 8 to 12 weeks post-injury, compared to treatment as usual, which was a multidisciplinary treatment offered at Oslo University Hospital. In addition to this, we conducted a feasibility trial before the randomized control trial to make sure that our manual and design was working as expected. We also, due to our findings, chose to conduct a cost-effectiveness investigation of the findings. And we also wanted to investigate potential work-related factors that may influence work participation in patients with persistent symptoms. So here is the study design that I just talked you through, and I will just say shortly about the intervention as such. So the cognitive rehabilitation part is what is called compensatory cognitive training. It's a 10-week manualized group intervention that targets psychoeducation about traumatic brain injury, management of post-concussive symptoms such as headaches, fatigue, sleep, stress management, and compensatory cognitive strategies such as learning and memory, organization, prospective memory, attention and concentration, and executive function. So typical cognitive problems after brain injury. Along with this, the patients also received, in the intervention group, received supported employment. So this was work support provided by employment specialists that had, previous to their training as employment specialists, had several years of experience in working with people with cognitive problems after traumatic brain injury. They established individual contacts and support at the workplace. There was an involvement of the employer and also the welfare system NAV supervisor. There was a main emphasis on the part of supported employment that is centered around client engagement, employer engagement, on and off the job support. The supported employment part lasted for 6 months, and that was a limit set by the research design as such. And there was also, along the way, regular meetings between the CCT, or the health therapists, and the employment specialists. So we discussed each case across both treatment efforts. And just briefly, the comparison group, the TAU treatment as usual, they received a multidisciplinary TBI rehabilitation program at the Department of Physical Medicine and Rehabilitation at Oslo University Hospital. What they received varied somewhat, but we had available a team consisting of a doctor, a psychologist, physical therapist, occupational therapist, and social worker, and also a group patient education system. So the treatment as usual is quite a comprehensive treatment in this study. The duration was set to 6 months also here. So the participants that we included were patients with mild or moderate TBI, 8 to 12 weeks earlier. They were between 18 and 60 years old. They had at least 50% work at the time of injury, and they were on a 50% or more sick leave due to post-concussion symptoms at the time of inclusion. And I'd like to note for you that we included patients in looking at the supported employment literature. These patients are early on after their injury, and they are employed at the time of injury. which differs from many other studies that have been conducted in this field. So our primary outcomes were, of course, work participation, defined as percent work, time until premorbid work levels, and work stability. And as secondary outcomes of the study, we also looked at patients subjectively experienced subjective symptoms of brain injury, their cognitive functioning, and their health-related quality of life. In the study sample, we looked at almost 600 charts to identify eligible patients. We ended up randomizing and including in the study 116 patients, with 60 patients being randomized to the intervention group and 56 patients randomized to the treatment as usual group. And then nada, the results.
So I will talk about the main quantitative results, and first some baseline characteristics of the participants. Regarding age, they were in their 40s. We had higher participation of women included in the study, in line with other intervention studies. 1/4 of participants had intracranial injury, bleeding or hematomas, and at brain scanning. Further, the majority of patients had white-collar occupation. They were stable employed at the injury time. Above 50% worked in the private sector, and the majority of patients were sick listed in 100% at the inclusion time. Our main intention was to describe the effect of combined cognitive and vocational intervention. And we published 2 papers. We did the interim analysis at 3 and 6 months, as well as trajectory analysis at 12 months. Here is the main results about the proportion of patients who return to work after mild and moderate TBI during the 1 year after the inclusion. And you can see that blue line is the intervention group and the red line is a control group. We found that more patients returned to work at 3 months in the intervention group. Statistically significant difference. There were also more patients in the intervention group that returned to work at 6 and 12 months. However, there was not statistically significant difference. And at 12 months, it was 90% of patients returning to work in the intervention group and 84% in the control group. Further, we assessed how many patients returned to pre-injury work level. And we took 50% at the first stage, and we found that in the intervention group, they returned to their pre-injury work level by 365 days. And we found 50 days difference between groups in favor of intervention group. Then we did cost and cost-effectiveness analysis of the intervention, and we found that costs were mainly related to the productivity loss, accounting for 84% of total costs. We found that costs of healthcare services and informal care each account for 8%. Informal care, this is about the support from family and friends in daily life activities for the consequences of injury. The mean cost of health services, some of intervention costs, primary care, and specialist care, another, was higher in the intervention group compared to control group. However, the mean costs of informal care and productivity loss, which is sickness absence, was lower in the intervention group compared to control group. So we did the cost effectiveness analysis using the incremental cost effectiveness ratio. And as you can see, we found that intervention is not cost effective regarding healthcare costs. We did the sensitivity analysis with bootstrapping on 1,000 samples to increase internal validity of the analysis. So all of the scatters above horizontal axis indicated that intervention is not cost effective. However, we found that intervention is cost effective due to society costs, productivity loss, and informal care. If you see the vertical axis, 76% of scatters are on the right side, indicated that the number of days earlier back to work in the intervention group is cost effective. Further, we examined the work-related factors because there was not that many articles in the literature about work-related factors and association with the work participation at 12 months. We had discussions with our colleagues from the Work Research Institute in which way we could describe the work-related factors. And we decided to use the 4 subscales from the Copenhagen Psychosocial Questionnaire, which assessing the psychosocial environment at workplace. So we used the predictability, which is about the information if employees are informed about the important decision they need in their work. Quantitative demands, if they have enough time for work task or they are using more time. And further, influence at work, if they are involved in the important decision at the workplace. And finally, reward, if their work is recognized by their managers. And as you can see, we compared our mean scores with the Danish mean scores, Danish employees' mean scores, and our participants, they are struggling more with the psychosocial environment at the work. We did first the global prediction model, where we included some of the socio-demographics factors, injury-related factors, and job-related factors, the 4 subscales from the Copenhagen questionnaire, and if they worked in the public or private sector, and if they are stable in the work. And we found that gender, symptom burden, if they work in public or private sector, predictability, they were predictive factors in our model. Then we did the final model, which comprised significant variables from the global model. And here I would like to highlight that women, they worked 16% less than men at 12 months after the injury. And those working in public sector, they worked 16% more than those working in private sector. And those that have problems with the predictability and quantitative demands, they are working a little bit more. And those which not getting the reward at workplace, they are working a little bit less. So the total model explained 25% of variance in the work participations 12 months after the injury. This is not that bad results. However, there is 75% of variance that is not explained with this model. So we should do further research, and we should include more patients, probably more than 500 patients, if we would like to assess several other factors of importance. We did the sensitivity analysis in this model as well. We used the 1,000 bootstrapping inputs. So that was main result. So Marianne will talk about main conclusions.
Thank you, Nada. So several conclusions. We believe that our study shows that early combined cognitive rehabilitation and supported employment may speed up the return to work process for persons with long-standing symptoms after mild to moderate TBI. We found that this is cost-effective on a societal perspective, largely due to the reduced productivity loss, which means lower levels of sick leave. And as Nada and I talked about before the talk, the numbers on the cost-effectiveness actually shows that sometimes you need to spend more money on healthcare to save money for the society. That's actually what the findings show us. It's more expensive at the healthcare sector, but it does save money for the society. Well invested money. So we also conclude that treatment efforts aimed towards the milder spectrum of traumatic brain injury should increase its focus on vocational rehabilitation. And the study demonstrates the importance of factors related to the workplace. Interventions combining medical rehabilitation and supported employment should be increasingly considered after neurological injury and disease, in contrast to in Norway, where I feel that the focus on the use of supported employment has mainly been in connection with psychiatric disease, which we will hear more about in a minute. We also conclude that supported employment may be effective also when patients have an employer when the work specialists are appointed, which differs from many previous studies. And the close collaboration between work specialists and health professionals should be tried out in clinical settings, as we know that a lack of collaboration is a severe factor hampering successful return to work for our patients. We also feel that the scientific collaboration between health researchers and work researchers has been valuable in promoting a more complex understanding of the predictors that are at play during the return to work process, and that similar cross-sectorial collaboration is needed also in clinical practice. So we would like to thank you for your attention, and also thank all our collaborators, all the institutions that have collaborated, but not the least the PhD students who worked very hard to produce this knowledge. Thank you very much.
Please join me here. Join me. Step in the spotlight, the place you love to be. Here we go. First of all, these are the lovely chocolates that all